My name's Charlotte. I'm Chief Executive at National Voices. We are the Coalition for Health and Care Charities in England. I have said many times we've got 170 members, but I've just gone through the list. We've got 180 members and counting. We have later on today a meeting for many of our new members, which is lovely. And we do almost everything we do in partnership. So this is a very timely event for us, very on message. We firmly believe that the sum, it tends to be more, or the whole tends to be more than the sum of the parts, something like that. That we achieve a lot more by working together. And in the little briefing we just had before we kicked off, we were talking about the vaccination program and how that was just one example of how this massive organisation, the NHS, with its immense reach and its very impressive ability to rustle up a vaccine really in record time, can reach some people, and that in order to reach them we needed to work with organisations that were very different from the big NHS and much closer to communities. And I think that's one of the themes we want to unpick a bit today. Can I ask everyone to go on mute who isn't speaking or isn't on the panel? Right. And I don't know whether Ella or Rosie can make sure that super that's the case. Right, so I'll quickly introduce the agenda and what we're planning to do today. We have got two speakers kicking us off talking about an innovative program, a quality assurance program that aims to get dialysis into people's homes. Peter, could you go on mute? Thank you. Because I can hear your room. Get it into people's homes, which is obviously much safer, particularly during a pandemic, and also leads to a small footprint of healthcare in people's lives, which is always welcome. So we've got Fiona and Paul talking about that. Fiona's from Kidney Care UK and Paul leads the Renal Association. And we've also got Catherine joining us from the Renal Association who can back up. And then we have another sort of cluster of partnership and issues. And we have Peter from Gilead Sciences talking about work they're doing to get some of their hepatitis drugs, I think, to communities who are often very marginalised and quite a long way removed from mainstream healthcare. And he's sharing the platform with Tracy, who runs an organisation called Change, Grow, Live, who help, together with many smaller community groups, make that happen. And then we have plenty of time for questions. And we also have colleagues joining us from a collaboration back to kidney improvements called the DAYlife panel. So a colleague from Baxter and from Fresenius Medical Care will be part of this discussion about how we can get innovative partnerships off the ground and how we can help them have better impact. If that sounds like you're in the event that you thought you are, please stay. We have some Mentimeter questions for you to get involved, but also, as I said, there'll be opportunity to speak later, to ask questions. You can put them in the chat. I assume you all know how to do that. At the bottom of your screen, there's a little speech bubble where I think people have started introducing themselves, but also you can pop questions in there and we see how it goes and how unruly or ruly you are as a group of people. We could also try to actually speak in person, depends a bit on overall numbers in the end and whether we can pull that off. I'll do my best to make it interactive. I have been very strict with the speakers and I will continue to be very strict with the speakers, that they don't ramble on for 45 minutes. And hopefully we'll have an energetic and interesting hour and a half together this morning. Okay, so I think without further ado, I'll hand over to Fiona, and I think Ella is going to share the slides for you. Over to you.
Oh, thank you. And it's nice to see some names I recognise there in the in the people coming in to join. I'll just wait while the slides come up. I can put them up myself if necessary. Oh, there they are. Brilliant. Okay, so morning everybody. So as Charlotte said, I'm with Kidney Care UK. I'm the Director of Policy there, and it's my pleasure to talk about a collaboration for inclusion, which is called DAYlife. And if you don't know what that means, hopefully you will shortly. And this is something that we at the charity have been working with some time with KQuIP, Baxter and Fresenius. And I'll explain KQuIP in just a moment. If you care to go to the next slide, please. Yeah. Okay, so KQuIP is a kidney quality improvement partnership. Now, if we go back 2 or 3 years, more than that actually, the renal networks in England had been disbanded. That means the funding had gone. And although there was a great desire for our regional networks to continue to work together, that became quite challenging and was fading away. So as a consequence, the community got together and said, actually, we really do need to keep our eye on what's happening within the networks. There is much to do to improve kidney care. And so between us, the Renal Association created, we supported with some funding and partnership, the Kidney Quality Improvement Programme. And that chose 3 priority programmes to focus on to improve care. And DAYlife was one of those. So DAYlife, dialysis at yours, to help living well, if you like, with kidney failure, which is quite a challenging thing, I can tell you. So we launched that in 2019. So the overall aim, as you can see there, is to improve quality and uptake of renal replacement therapies. That means dialysis, which is the treatments you can have if your kidneys don't work anymore. So it's life-maintaining treatment. And it was overseen by a partnership board with a small operational group in there. And I know Catherine's part of that. So next slide, please, Ella. So DAYlife itself is a unique tripartite arrangement. To my knowledge, we have never done anything like this before. So it's the NHS, it's the charity, kidney care, and industry partners, that's Baxter and Fresenius, working together. And so I say that, it's joint funding, but actually it's not joint funding in the way that you might think of it, as in one of the parties just putting some money in and kind of stepping back. It's actual partnership around our shared or common purpose, which is patient benefit. And we tried to illustrate that very clearly at the original kickoff event, whereby Baxter and Fresenius representatives stood next to each other at the stand and spoke together alongside one of our advocacy officers and of course NHS kidney doctors there as well. So it was symbolic, but it's the way we intended to go on, and the way in fact we have gone on. So the programme used a QI approach to kind of choose which way to go, and local units within initially the East and West Midlands network led the way on taking this programme up and adapting it for their own group of patients, to bring forward the opportunity for those people to be encouraged, to be supported, to go home to dialyse. Next slide, please, Ella. So I just have to, because I know that many of you won't know this, I just want to explain why it's a really good thing for people to be able to dialyse at home, should they wish to. Basically, it saves you 3 days a week in hospital. You can do it in your own time. You can do it more frequently, although obviously it still takes up an enormous amount of time, but there are fewer diet and fluid restrictions. So a lot of people will choose to do it overnight, although there are nevertheless challenges to that. And it gives overall better long-term outcomes. During this last year, it's also been shown to be much safer because, of course, you have no interaction with anybody else through the transport and the waiting or having treatment in busy hospital units. But it does require a huge amount of patient motivation. It is a treatment which involves all sorts of needles and connectivity and complex things like that. It requires infection control, infection management, and it requires lots of space as well. So it's not something you can wave a magic wand at. Next slide, please, Ellen. So what does NICE say? So NICE says that this should basically be a shared decision informed by clinical considerations and patient preferences, but we are nowhere near that at the moment. I think NICE recommended in 2002 something like 15% of people on home dialysis should be on home dialysis. I think we're at 4% at the moment. But the reason for variation, no time here to go into them, but they are complex, they interact with each other, and there isn't one simple solution. Otherwise we might have arrived at that, but hence the quality improvement approach. So if we could go on to the next slide, please. I just also want to mention something that we did prior to the setup of the DAYlife programme, which set us, Kidney Care UK, in a position of trust, I suppose, or the relationship of trust with Baxter and Fresenius. we together, the three of us and kidney units, went out probably in about 16 to 20 hospitals across the country to run a range of roadshows where peers would come in the camper vans actually, and meet with kidney patients to talk to them about their treatments and how it was for them. So that was supported with our advocacy officers, and our partners again brought in a sort of, you know, the communications. They helped bring in the, you know, things like catering and the camper van itself, but they were they nevertheless showed this really untapped appetite for home dialysis when you take it out there to people. So, and that went up by people. I don't just mean patients, I mean staff as well, in whom there's quite a low level in some places of awareness on it. So as I say, that built us up in a situation that when the KQuIP that came along, didn't turn up, you made it between us, but we were in a, you know, a good position to do that. So we could, and I just wanted to just give you an idea of the sorts of people we're talking about here. So up the top there is Farah and her daughter, who were able to go. Farah was able to be supported by her daughter to dialyse at home. And at the bottom there, you've got Ernest and Marjorie, who are busy telling some other patients about what it's like for them to take their dialysis at home. So if we go on to the next slide, please. So what are some of the key points of this? So each partner, as I already said, it wasn't. Obviously, you do need funding to support these things, but it was actually each partner bringing in their own unique skills and insights. So whether that's on the systems, of course, that intense, you know, very detailed and wide medical knowledge is vital to support this. But, you know, smart methodologies, Anne will be able to talk about that, I expect, anon. And from us, of course, it's very much the patient partnership. Senior leadership from all partners to sponsor this, to be accountable to see it through as we go along, and that continues now. What happened? Well, each unit that was involved worked in a slightly different way, following some of the kick-off events and their own ways of doing it, but it showed increased uptake. And we found that, of course, measurement is really important. Patient-reported experiences and outcomes being part of that. And the partnership built in patient representation. That's very important to us at local, regional and national levels to enable our diverse, because we have very diverse populations who have kidney failure and who will need to be supported with dialysis. I should say that some of you may expect that transplant is the main thing for many people, but actually, while that's vital, we have across the whole country there are 30,000 people on dialysis, and only 5,000 of those are well enough to be on the transplant waiting list. So you see that this is vital for people's lives. Needed to be supported by data tools, IT collection, and because the units chose to come forward to take part, to train up their QI leads, there was a lot of highly motivated multidisciplinary teams at the heart of it. And the team themselves needs to constantly work with their patients to support them through this challenging pathway, to make sure that people are there and that we can sustain it. So my final slide, if you will please, Ella, next slide, is that I believe we're now in a situation where we can jump into what the long-term plan is talking about bringing care closer to home. It was always an aspiration for home dialysis, but by doing this work together, the kidney quality improvement networks led to, if you like, renal networks that were brought back in by NHS England last year and are now funded because of COVID. An opportunity to become part of an integrated care system. We're now looking at spreads to other networks, hopefully the Northwest and perhaps in London as well. And here within renal, we're actually supported by the start of a large 3 to 4 year transformation programme and the results of a Getting It Right First Time GIRFT investigation, which has highlighted home therapies as a key place for improvement. So by establishing the partnership, by developing the QI tools and the knowledge, the reporting and the IT and the measurement tools, we're by no means there yet, and I can anon talk about some of the barriers to that, but we're certainly ready to use the opportunity now. And I think I need to stop there and hand over to Paul. Thank you.
Super, thank you, Fiona, and you stuck to your time. Very much appreciated. Really inspiring initiative. I know, I appreciate it's early days and probably the pandemic set it back somewhat.
Yes.
Even though, as you said, there's an added incentive really to keep people in their homes rather than to drag them into busy hospital units. But we can unpack that a bit later, maybe sort of pandemic effects. I'm sure that comes up in people's minds as we think through how to apply that to our own work on our own wicked problems. Right, I'm handing over to Paul now, who will give the sort of professional perspective on this. You're sharing your own slides, aren't you?
Yeah. Well, it should be. Can you guys see this?
Not yet, no.
Oh, okay.
If you stop sharing and try again, you need to have your presentation open.
I do. No, it's not letting me do this.
Do you want to send them to Ella?
Yeah, let me send it to Ella.
I'll just put my email in the chat.
In the meantime, Kerrit's just asked a quick question that maybe you and I want to just quickly talk about, and it's just about the barriers for South Asian patients lacking confidence. Maybe we should just quickly.
Yeah, definitely. Yeah, I was thinking we could definitely to discuss this. Yeah.
I mean, and Paul, you'll have some comments on that, but one of the things that I would suggest, and the reason that's one of the reasons I shared Farah's picture up there, because I thought she was that family were really inspiring. And what they did, this was before KQuIP, but what they did was they actually, the team supporting them built a very strong trusted relationship, and they were able to, because they were able to visit the home back then, they were able to kind of identify the sorts of support that the daughter, because it was actually Farah's daughter that was helping her to dialyse, that would be something that would work for them. And you wouldn't know that unless you got to know the family, and that was the way in which to build that confidence. Paul, do you want to jump in?
Yeah, give me a second.
I wonder, Fiona, may I comment as well? It was just from an industry perspective. So part of the collaboration was about all of us being able to see all of the resources that are available. And one of the things we have done is recognise this challenge as well, and translated a number of the patient literature into multiple languages, and also used step-by-step picture guides within them. Again, all aiming to help people feel more comfortable and more confident for home therapies.
Paul, are we ready with your slides, or shall I bring Kirit in maybe to give his perspective?
Yeah, you should have them, Ella. They should have come from a Gmail address.
It hasn't come into my, it's just come in now.
Okay, cool.
Okay.
Can I just make a couple of points that, for context, actually, to start with? I don't think it's understood how diced and sliced the NHS is. One of the huge challenges is that because each provider in the NHS is essentially being franchised, what we mean by provider, we mean a single NHS organisation. And for the purposes of kidney care, specialist kidney care, that will be an NHS trust. But those NHS trusts have huge variability in the way that they're configured, in the way that they staff, in the way that their infrastructure is. So a lot of the variance that you see is driven by the fact that the NHS, my analogy is like a group of Kentucky Fried Chicken franchises. So that there is no overall system structure that can truly traction equity right across the National Health Service. And it's hard to overestimate what the disruption of the provider model has been in the ability to deliver standardized care right across a single system. So the assumptions are that we've got a single system, but of course we've not got that. What we've effectively got is individual clinical services needing to be advocates within single complex organizations where there are a lot of competing priorities. And historically, renal care has been cannibalized because the funding streams that have come in for kidney care, particularly around dialysis, are in excess of that required to provide care. So home therapies is a very good example of this. It doesn't suit NHS organizations to grow home therapies because the historic tariffs for in-center hemodialysis are sufficiently high to give the hospitals a profit margin, okay? And that profit margin is then used to subsidize other areas of care, often non-renal care. So there's a lack of transparency then in terms of the financial reporting by NHS trusts. So whilst we could talk about some of the contexts in terms of delivering change at a service level by focusing healthcare professionals, what we've also got to understand is the broader context in a broken system where you've got a lot of imaginative accounting in NHS trusts that nail down financial models that drive inequality in the system. So I'm not sure whether I've explained that clearly enough, but I just wanted to give people a feel for that and a real benchmark for that. It is a huge problem. And one of the challenges going into a time of incredible change is that actually organizations have become more conservative. So as you move from into integrated care systems, the assumption is that things are going to become more agile, whereas actually the risk is that individual large trusts that sit within integrated care systems will look to preserve the status quo so they can preserve their financial streams as effectively as possible. So that's just a marker, the context within which we discuss in the change that's coming through in the work that's being done this morning. That's the first thing. The second thing is to say Catherine's done most of the heavy lifting on this and has done a fantastic job as the program manager for the DAYlife theme for the Kidney Quality Improvement Partnership. And it can't be overestimated the huge amount of work that Catherine's put in terms of leading this, and where we are is very much due to her. So next slide, please. Okay, so Fiona's given you a lot of background, just to colour a little bit of that background in specific areas. So the Kidney Quality Improvement Partnership, as you've heard, is a national network, and it's really there to support quality improvement in kidney services. And, you know, people often get confused about quality improvement. And the analogy that I would give you, if you think about individual experience as a patient and individual skill sets as any given healthcare professional working with patients, that is the core relationship for anybody coming through with a specific clinical problem. And that relies on the skill sets of the individual healthcare professionals that you're coming into contact with. Those individual skill sets can only be appropriately exercised if you've got a system that's working as effectively as possible. And quality improvement is about how does the broader system work as effectively, as efficiently, and with as much value as possible to optimize patients' both experience and the quality of care that they get as they move through any particular journey that they have in relationship to any particular disease that they have. And there's a lot said about quality improvement in the NHS, but one thing, and I'm being tough on the NHS this morning, I know, one thing to remember is that the NHS puts very little into quality improvement that actually embeds into healthcare professionals' job plans. So healthcare professionals being able to do quality improvement day by day and week by week through their jobs. And as a consequence of that, it's led to large partnerships such as the one we're talking together, which aren't NHS partnerships. These are partnerships out of the professional bodies, patient bodies, industry partners to drive quality improvement. So DAYlife consists of 3 national projects, and the project that we're going to talk about today, is the DAYlife project that Fiona's fleshed out for you. And the broader context of KQuIP is that it's developed an extensive infrastructure, including a toolkit, as is shown on the left-hand side, and including a systematic approach to be able to develop healthcare professionals to be able to make quality improvement changes within their organizations to help improve patient care. And quality improvement is complex because there are multiple factors to it, and the requirements for quality improvements differ dependent upon the system and dependent upon the organization. Next slide, please. Thanks. So when one thinks about dialysis and quality improvements as it relates to dialysis, there's a couple of top lines to remember. One is that there aren't that many people who get established kidney failure requiring dialysis treatment in the UK. So if you think about kidney disease, around 1 in 7 people, 1 in 7 adults will have kidney disease. That is, you know, whatever, 8 to 10 million people in the UK, but only 60,000 or so people have established renal failure. That is, the kidneys have stopped working, so that individual would die without replacement treatment. And replacement treatment is broken down into 2 types of treatment. One is kidney transplantation, and around 55% of people in established renal failure have functioning kidney transplants, and then around 45% of people are treated with dialysis, and dialysis is replacement of kidney function. And there are 2 ways of doing dialysis. The first is hemodialysis, which in short plunks a patient into a machine, takes the blood out of the patient and then circulates that through an artificial kidney, and that is usually done in dialysis units, what's called in-center hemodialysis. So the large majority of people receiving dialysis get in-center hemodialysis. And then on the right is peritoneal dialysis, which is a home-based therapy where the patient utilizes the lining of the bowel, the peritoneum, which acts as a biological dialysis membrane for the purposes of removal of waste product. So peritoneal dialysis always occurs at home. Hemodialysis can occur at home, what's called home hemodialysis, but in fact, a very small proportion of people in the UK get home hemodialysis. When you compare home therapies, that is peritoneal dialysis and home hemodialysis, to in-center hemodialysis, there's good evidence to show that home therapies are associated with better quality of life for patients receiving dialysis treatment. And that spans both peritoneal dialysis and home hemodialysis. It's very difficult to do direct randomized controlled trials, that is to compare outcomes, but there are some signals that in some groups of patients, people may live longer receiving peritoneal dialysis, and people may live longer receiving home hemodialysis. And in addition, there's better value of home therapies. What does better value mean? Well, if you strip everything out and you say there's equipoise between the therapies, it's substantially cheaper to do home therapies than it is to do in-center hemodialysis. Next slide, please.
Paul, I need to remind you that we're kind of running a bit late.
Yeah,
so.
that's fine. And so here are the overall figures of home dialysis in the UK. You can see that despite the better associations with value and outcomes with home dialysis, that only a small proportion of patients, less than 20% in total, are on a home therapy. And on the right, you've got a funnel plot, and that shows the huge variation in renal services across the UK in respect of people receiving home therapies. Next slide, please. So when we focused on home therapies for KQuIP, we took a multi-factored approach that embedded this partnership between Kidney Care UK, industry partners, and healthcare professionals to look at all the angles that one could take in terms of enabling services to develop approaches to quality improvement that specifically focused on home therapies. And some of those approaches are listed here, and you can read them. and would be very happy to share these slides afterwards. As a baseline for this, there are two key things to remember when one's looking at quality improvement. The first is the NHS change model, and go and read about the NHS change model. So that's a substantial piece of work identifying how one changes within the National Health Service in terms of delivery of care in any particular area. And the other is the Institute of Health Improvement methodologies for quality improvement. So those were exercised or used throughout the KQuIP program. Next slide, please. And here's a timeline for where we got to with KQuIP. We took people through over an 18-month journey across renal services in the Midlands, bringing people together, helping them identify the key areas for change within each of the programme to increase the number of people requiring home therapies. And that led to substantial change with time across a number of services. And then, of course, we came to a halt with COVID, although it must be said there are some pretty strong signals that in some services, home therapies have had an increased focus through COVID, and indeed in some therapies and in some centres there were increased numbers of people going on to home therapies. Next slide, please. And this is you know, an overview from a single centre. This is Shrewsbury and Telford Hospitals NHS Trust, and this is a run chart. So what you see on the bottom right is you see how you can measure change in time in the quality improvement programme. And if you're looking for change in a quality improvement programme, what you're looking for is to see 4 data points moving in a particular direction. So this run chart shows that during the period of the DAYlife project, there were increasing uptake for home therapies in Shrewsbury and Telford hospitals. Next slide, please. So the overall points for debate, I guess, for this morning is what do partnerships bring? And what was notable for DAYlife was that by bringing the partners together, we were able to develop trust across organizations. So organizations, of course, can become very insular, and bringing a partnership model together allows people to look and see what the challenges are from a patient perspective and an industry perspective. The patient perspective, of course, is crucial because patients drive change at an organizational level in the NHS, and patients set the tone, or should set the tone, for what quality really looks like. Industry added real expertise in sustainability, and you know, Fresenius and Baxter colleagues had a huge role in bringing skills that weren't present within NHS organizations. The challenge is, there are a number of challenges, and the key thing for me is about defining the relationships, in particular ensuring from an industry perspective that there's transparency, that there's strong governance and a strong leadership structure. Measurement must be at the heart of quality improvement. Often you see QI projects and there is no measurement. And then this challenge as to how you generalize quality improvement across healthcare professionals. And as you develop a partnership model, ensuring partner voices. So that's my slides, and I'm sure there'll be plenty of questions coming through. I'm sorry about the delay in getting that.
Thanks, Paul. It's now Peter speaking, I think, and at the same time, I'm going to post a question in the chat, and it would be great if you guys could follow that link and answer the question on our Mentimeter for us to have a look at later.
Could you post that again, Ella, because I think it's moved up quite sort of out of sight. Yeah, right. So we've heard from our colleagues who work in kidney care and what they're doing to improve things and to build patient-centeredness into it. We're now hearing from Peter from Gilead, who is going to talk about a very different patient group. Peter, over to you.
Yes, thank you, Charlotte. Good morning, everybody. Delighted to be able to kind of tell our story. There's a lot of commonality, I guess, with what we've heard with Fiona and Paul, which is reassuring. And what I do have to apologise. This is a story about viruses, but hopefully one that's got a bit more of it's a little bit different, and I'll tell you why. So if we just go to the next slide, please, Ella. So hepatitis C, for those of you who aren't familiar with it, it is a blood-borne virus that affects the liver. What that means is that the way that virus is transmitted is when your blood comes into contact with somebody else's blood. The good news for this is that in recent years, Gilead and other companies have developed products that cure this virus. So you can take a short course of oral treatment, and you should expect in over 95% of cases that you'll be cured of that virus and not have to think of it again. That is if we can find and treat people before the virus has impacted on their liver significantly enough to cause cirrhosis and the need for liver transplants, hepatocellular carcinoma, etc. as well. So because these cures are now kind of widely available, WHO has committed to eliminating hepatitis C as a public health threat by 2030, which essentially means taking so much virus out of the circulating population that it's no longer considered to be an active threat. And for reasons I'm going to go into, NHS England is committed to doing this by 2025. Now, the population of people that this affects, as I've said, in that kind of blood-to-blood contact, the likelihood is that in today's population where we see that is with people that inject and use drugs through injecting means. Now, the challenge is that by and large, the virus itself is asymptomatic, certainly in the earlier stages, and some of the symptoms you might commonly expect to get as the disease progresses. Things like fatigue and so forth are probably not that different enough to be noticeable. So what we have seen as hepatitis C treatment has evolved is what used to be a very NHS specialty care led process, up to a year of treatment, regular injections and so forth, is we've now got this whole system set up in hospital to treat people that way. But actually, that's not what the patient's looking for now. The patients will need to be identified and actually as much of that care pathway brought to them as possible. And I think, as the previous speakers have highlighted, there's an incredible level of fragmentation that happens across how health and social care is delivered in England. So if we move on to the next slide, what NHS England asked the pharma companies to say is that actually there's a need here for a lot of stakeholders to come together if we're going to eliminate. There are things NHS England can do, such as put these tenders in place, giving a longer term to the commissioning of the medicines, but actually asking the pharma companies to bring their own skills, expertise, and investment into helping support those patients into care as well. So I'm delighted to say that kicked off as of March 2019. Coming into that, sorry, next slide, Ella. Coming into that, we have to kind of humbly, sorry, there might be a build here, so if you could just build it out, I think it's just 2 clicks. What you see there across the bottom there is a typical pathway for how somebody might be diagnosed and then treated for hepatitis C. Across the top, what you would see is the kind of the red jelly beans, as it were, are showing kind of the NHS saying, as soon as people come to us, we can then move through and we'll take them through all of the steps. But you have to come to hospital for that to happen. And that's kind of where we were maybe as short as 2-3 years ago. But increasingly, as more and more of these patients were treated, you're starting to get to a less symptomatic group. You're more reliant on those partners with the green jelly beans on the left-hand side to be identifying those patients and referring them through. Actually, that's not enough. And what you need to do is we get to the bottom to support patients through those pathways is you need to redesign those pathways around them. So we spoke with a lot of stakeholders, and the first to understand how we could best support. And I guess the thing that struck me the most was just how many different stakeholders there are, different patient organisations, prison healthcare, addiction service healthcare, etc. And if you move on to the next slide, Ella. And one of the things we met with Change, Grow, Live, and I will say we're going to talk a lot about the partnership here. Almost that first step was the hardest. Why would this organisation talk to us? What have we got to offer them that they don't already have, and so forth. But actually, when we spoke with Change, Grow, Live, one of the addiction service providers, and who are represented here today by Tracy, they were quite passionate about this as well and saw this as a way to really support their clients. Their experience was that actually they probably had enough of the resources on the ground to make do, But if they wanted to drive change through the organisation, their ask was, could we support them with building in a kind of a tier of regional coordinators? So for our partnership, what we did is we fund 4 regional coordinators and some data analysts as well. And we also fund our own team that's on the ground that sits within Gilead and works closely with the team within Change, Grow, Live, but also with the NHS, other third sector providers and charities and so forth. A number of the types of different things that we do there around kind of awareness raising. So we recently had an event kick off in April for a testing event in March. For those of you on Twitter, there's some fantastic photos there. But actually, we're also a very data-driven approach and looking at where there are opportunities to kind of improve both the testing levels, but then ensuring that the patients that are being referred in are making it into treatment and able to be tested. Prior to the pandemic, about 1 in 3 patients was now being treated through a drug treatment service. And we've had, I guess, the confidence in this approach and the recognition that this approach is working, that we've now been able to extend this to all the major leading drug and alcohol service providers in the country as well. In the top right-hand corner there, what we've been able to do is with those partnerships that we now have, these organisations and addiction services who are typically set up, I guess, in competition as they compete for different tenders by the different local authorities. Actually, what we found is this is a common ground where they're all very keen to work together to say, how can we, well, if we're going to eliminate, we all need to eliminate. And I think what we've been able to do is to bring them together, knowing that they each have that kind of shared goal and a commitment to eliminate. We've actually been able to bring people together, come up with plans, come up with shared awareness events, and really starting to work collectively. If we go on to the next slide, the other place where there's a high prevalence of hepatitis C is within the prison estate. You might think it's quite easy to test people in prison and treat them while they're there, but for a number of reasons, it's more difficult than that. Again, what we found is a different set of partners, so working with the patient organisation Hepatitis C Trust, but also the healthcare provider within the prison estate. And we've looked at 2 things there. One is improving the uptake of testing as people are received into prison. I'm delighted to say that despite the pandemic, we've seen testing rates go up as high as 81% as recently in April 2021, which is a testament to the people that have been involved in that and our partners. We also try, stigma can be quite an issue in prison as well. So one of the things that we have found to be quite successful is going in and essentially testing the entire prison over a series of days. That's been really well received. Everybody gets a Mars bar and phone cards and other incentives, but essentially as you're going kind of wing by wing, that doesn't isolate people or individuals who feel they might be stigmatized by putting their hand up for a test as well. If you go on to at the point where we're writing the slides, but I think we've talked there about we are very different organisations, being a pharmaceutical organisation and any of the organisations that we work with as well. And I think everyone talks about trust. I think it's absolutely fundamental, and I don't think you can get where the true partnership comes in. And I think you start to find out just how much trust you have when there's friction in that relationship, or when you're looking for perhaps ways to adjust how you're working together. Certainly the patient need has been central to this. And I think what's been important for us is, I guess, no one has a monopoly on understanding what patients need on might want. So I think you've got to be humble enough to build, to listen, to refine, and certainly as we move towards elimination, the groups of patients that we're working with are changing as well. Metrics are absolutely bread and butter for us. I think we need to prove not just are we being successful, but also where else perhaps where are groups being under invested. So I think we've got a lot of qualitative input already. The quantitative piece has been the bit that we've really built out. And I think, you know, I encourage everyone to look at how can you set those goals of where you want to get to together, and then course correct together as well. I think the very last point, the celebrating the successes. You know, we've been delighted at some of the feedback and response that we've had, not just the numbers of patients that have been treated and cured through this, but equally, you know, the individual stories that you hear about how this has impacted on people's lives, and how this might, in many cases, be the first positive healthcare interaction for quite some time for this patient group. I'll stop there and let Tracy pick up at that thread, but thank you all for your attention.
Thank you so much, Peter. Really, really interesting. And as you say, a lot resonates with what Fiona and Paul were saying. Tracy, what's your perspective from a community organisation on this programme? Over to you.
Thank you, Charlotte. I think Ella is going to share some slides. Brilliant. Okay, so I will just start by introducing myself. So my name's Tracy Kemp, and I am the National Hepatitis C Strategic Lead at Change Grow Live. And I'm just going to pick up from where Peter left up and talk about and share kind of some examples of how we work together to improve outcomes for marginalised and underrepresented groups linking to hepatitis C. Next slide, please, Ella. So just very quickly, for those of you who are unaware of what we do and who Change Grow Live are, so we're a third sector organisation, we're a health and social care organisation, and predominantly we work with people who have issues with substance use, so drugs and alcohol. So a lot of our services are integrated health services, where we will initiate prescriptions for opiate substitute medication or support people with alcohol detox. However, we do deliver a vast range of other services, so specialist criminal justice services, homelessness services, young people services. So feel free to have a look at changegrowlive.org if you want a little bit more information on what it is that we do. Next slide, please, Ella. So I'd like to kind of start by providing a little bit of context, and I know Peter's covered some of this within his slide, but around the history of hepatitis C and kind of the partnership between ourselves and Gilead Sciences, because as Peter's kind of described, it was new and first of its kind. And I think it's important to recognise that whilst there's a partnership between ourselves and Gilead, there's lots of other organisations and lots of other people who are involved in this, and kind of the efforts to eliminate hepatitis C. So on the back of the partnership between CGL and Gilead, we were fortunate to develop that dedicated team. So that was our way of really kind of taking things to the next level, if you like. So we were able to develop a team whose sole focus is to engage with partners and build relationships with local NHS trusts, the local operational delivery networks, the dedicated team within Gilead, and the focus all the time is around how can we better engage and provide better outcomes for marginalised groups. On the back of the partnership, we at Change Grow Live developed our first ever organisational strategy around hepatitis C, and this was kind of our way of really identifying our aims and ambitions. And before moving on, just to share some examples, I think it's a perfect opportunity to talk a little bit more. I know that Peter shared this within his slide, but in 2019, Gilead, NHS and Change Grow Live were awarded Best Partnership of the Year at the Health Service Journal, which I just think really shows how key the relationship had become so early on in the collaboration piece, really. So something that we're very proud of. Next slide, please, Ella. Okay, so collaboration and what we have achieved so far. I think it's important to point out at this point that Hep C testing has always been a focus and an intervention, not only just within Change Grow Live, but across all drug treatment services. However, the partnership and the collaboration with Gilead has enabled us to really shine a light on this. And I suppose this was our way of kind of really thinking big and how can we do more. And since the collaboration, we have actually seen a year-on-year increase in numbers of people who've been tested and then gone on to access treatment for hepatitis C, which is exactly what we wanted to happen. Yes, COVID did impact that. However, we're coming to better enable people to engage in services. Some of the examples of how we've been able to do that: we've worked with local trusts to bring in specialist hepatitis C nurses into substance use services. So whereas historically people would have to go to their local hospital for their assessment appointment, let's say for to access hepatitis C treatment, what we now have is on-site treatment clinics, which massively reduces barriers for the people who use our services. The people who tell us that when they're at hospital, they feel stigmatized, and there's a lot of shame around kind of their substance use, and that sometimes is they carry that and often don't attend their appointments. So the fact that we've got on-site treatment clinics really helps and supports that. We engaged in a pilot alongside Gilead around drug delivery pathways. So what that means is we are now able to hold medication for hepatitis C in services. So again, someone could walk into a substance use service and receive their test in service, their treatment assessment in service should there be a need, but then also the specialist Hep C nurse or the home care provider can deliver an individual's treatment to the service so that it can be picked up from there. So we're literally trying to create an end-to-end package that reduces and breaks down those barriers that people tell us all the time that they are facing.
I need to ask you to speed up a bit if you may. Thank you.
Another initiative is the health buses. So what we've done with that is we are literally delivering testing and treatment to people's front doors. So sometimes, for whatever reason, people cannot come into services to be tested or to access treatment. So we've taken that to their front door through the use of a health bus. And then the final example is a self-test pathway. So we, during COVID, developed a toolkit that enabled people to test themselves at home for hepatitis C. This approach is used in lots of other areas, so I know sexual health adopt this approach, but to self-test yourself at home, and we've had so far 1,576 people from August of last year through to March of this year who have engaged and completed a self-test at home. Next slide, please. I'll just finish off here. So in terms of what's next, we are going to moving forward, use what we've experienced in the past 12 months to kind of continue to build and develop a strategy that enables us to do more. We'll continue to identify trends and themes. We're looking to implement more drug delivery pathways across substance misuse services. And I don't have time to talk about this, but the rough sleepers funding, this is kind of going to really bring an opportunity to engage with the homeless communities in areas that have received funding through this new initiative. Thank you, and apologies, Charlotte, for
No, you didn't run over. We were just running a bit late. Thank you, Tracy. Really interesting. I'm sure we can unpack in our conversation now sort of how you also partnered up with other communities and organizations. I've been watching the chat for questions, and 3 jump out at me to start with. So I think I'm going to bring in Kira to ask a question about peer support and the role it might play alongside and within these pathways to improve access and to improve experiences and outcomes. I'm going to bring in Louise to ask a question about culture, because I think that is writ large on a lot of the kind of problems that you run into when you build partnerships. And maybe we start with a question Mark had about finance. He asked a number of questions, and I think it also featured in what Paul said, that the way that finance is locked into the system can run counter to what we actually want to achieve for people. Mark, do you want to briefly say something? I know you run a small organisation in the north around peer support and mental health, around your thoughts on this. I can maybe unmute you.
Yeah, the things we've found is that because we may not be as literate as some people may be, and you're right, we are small and we do peer support in the home to battle, you know, people who may be a bit excluded or isolated. We find that the barriers go up when we try to go out for funding, or, you know, most funders are asking so many different questions that you might need, you know, a ready reckoner and a slide rule to work it all out and to get that the appropriate wording in the appropriate space. And just really want to get the thoughts on that if we don't fundamentally change the way we fund projects or we fund, you know, third sector, then how can we actually truly get a person-centered care approach when, you know, the monies are going to the bigger, larger projects who's already got the money and already got the people in place to write these bids?
Thank you, Mark. Fiona, I just wonder whether you have any thoughts on that. Like, you know, you're not a massive charity at all compared to the disease burden you are tackling. You're actually, you know, arguably not very big. But do you, in this project, do you think through partnering up with more community-based organisations or maybe more inequalities-focused organisations, has that sort of come up for you?
Yeah, you're right. I mean, we're not. I mean, I was just thinking back. Actually, when I joined 7 years ago, there were 7 of us at the charity. We have grown. Wow. We have grown quite a lot. So, and we don't get any, you know, funding from government and so forth. Although, so I suppose if I look back to where we were to where we are now, which is a larger organisation, I think that, you know, collaboration is basically the watchword here as well. And so we have done things, we have run events, we do work absolutely with groups of different sizes in order to bring forward specific programs and projects, because that's sometimes the way to get that I won't use the word hyper, but I'm going to, because that really local insight, because there may be people who are particularly, you know, I take that there's a particular initiative, you know, Black living donors. It doesn't have to be, you know, it doesn't have to be financial, just there's a partnership there as well. So there's an organisation that's doing some fantastic work with living donors in the Black population, and so we're working with them to help on that, because they've got, you know, the insight, and we've got some advocacy to help with that jointly, and perhaps it can be comms that can be shared as well. So I suppose the nature of it is to be adaptable to what's needed, to be open to collaboration and flexible to innovation and different ways of doing things. And that would be my sum up of that.
Yeah. And I know, Peter or Tracy, you obviously work with a kind of generally marginalised community almost, but there might still be sort of blind spots within that where you might have made progress for this cohort but not for that cohort. Have you got data to think that through, and do you know who you need to partner up with to get to people, or do you feel you've got the reach between the two of you?
Yeah, Peter. So I think naturally, dependent on the group of people, so for example, the homeless community is a group of people who we are really focusing on and targeting moving forward, because, you know, that they are a hidden group, so it makes them more difficult and accessible. Yes, we do have data that kind of can lead us to and tell us a little bit more about the story, but ultimately I suppose it's about working with our partners at Gilead and the patient access to care team to plan and you know, really just get out and find them. From our perspective, it's getting our staff, we're in a fortunate position, we've got staff on the ground to get out and go and find these groups of people, and looking at the data to tell us exactly where the gaps are in terms of who we do need to engage.
Peter, do you want to add something to that?
Yeah, I will actually, thank you. And the role of peers has been crucial as well. So I would say that each of the organisations we work with has their own kind of peer structure, but actually also the Hepatitis C Trust has been commissioned to set up peer networks across the country as well, and they've been fundamental. And I can guarantee you, if there's a patient population that's been left behind, they will let you know. I guess the question for us that we've had to focus on is, where do you start? you've got a laundry list of all these people that are kind of being failed by current processes. That's why this approach was taken. And one of the things, I guess, that we kind of came to quite early with Change, Grow, Live is to say, well, actually, the fundamental group that we need to be eliminating in should be the people that are coming into your services on a day-by-day kind of basis, because they're coming in, we can test them, we can get them treated. But as we've gone along, we've mapped out all these other groups that perhaps use needle exchange but aren't connected into more structured treatment as well. So we've run pilots where we've looked at how can we effectively deliver care to others. And the idea is to start with the services themselves, I guess, as a backbone from which you can then engage with homeless communities, needle exchange, and other groups as well. But I think, yeah, it's boring to say so, but I think with the data does help form some of these quite passionate discussions and say, well, if we could do one thing and do it well, how do we balance that for now?
Right, Louise, you posed one of those wicked questions around culture. I wonder whether maybe Anne or Victoria, who we haven't heard from yet, who are also involved in this kidney program, might want to pick that up. Louise, do you want to just say it in your own words?
Yeah, it's interesting, isn't it? We're a really small organisation and we're working with a pharmaceutical company on delivering sort of patient education, and collaborations start with enthusiasm and excitement, and the patient is central. And we found that as the months have gone on, the pharmaceutical company is bound by so many internal legal requirements, processes, sign-offs, and the burden on my team is enormous. It's we're too small, really, and it's quite limiting. It's limited the ways that we can reach patients because of the pharmaceutical company and their compliance, really. And I think, you know, we've learned something and we'll ask better questions next time. But yeah, just wondering if there's anything that we could do better or that you've learned as you...
Or even just what it's like from the other side. Anne and Victoria, do you want to pick that up?
Yeah, I'm happy to start. It's Victoria. Sorry, I haven't got a camera on because I'm really struggling with with Wi-Fi. I think what you described there is absolutely spot on from the pharmaceutical medical devices perspective. The compliance structures that we work within are huge and can be very, very, very prohibitive, I think, to get things done effectively and in a timely manner. And certainly from our side, I'm sure Anne will agree, it can sometimes feel very, very frustrating because we can see the potential, we can see what we want to do to support everyone, and we are literally so bound. And for the most part, I think it's necessary, because what we don't want to do is to ever be in a position where patients or organisations are maybe exploited. Or there's potential there for exploitation. So it's absolutely crucial. But I would say that what is key is agreeing from the outset that shared purpose and being able to see where you're heading and having that alignment for the future. I think transparency is huge. It's crucial because there needs to be an equal benefit for everybody involved. That's absolutely key. No but one party can be seen to be benefit more than the other. And I think people need to feel safe. You've got to, the culture has to be safety on all sides. So that would be kind of my take on that.
Yeah. Do you have something to add? Would you have any tips for how to make such partnerships feel less stilted, maybe? Or is it about really having a concrete issue, topic, data point almost you are collaborating around? Does that help, or what do you think helps?
Yeah, definitely. I would completely align with what Victoria was saying around having this common goal, this shared purpose. For me, it's all about openness and transparency, and that's what builds the trust. I think when you were talking around top tips, one of the things I would say is this has been not a new issue, tackled for years and years. Somebody who's been in this industry for just over 30 years now. And there are a number of toolkits produced over the years. So both whether you're in pharmaceuticals, you follow the ABPI and their regulatory guidelines. In medtech, you follow ABHI. ABPI, a few years ago, worked with the Department of Health to create a toolkit for joint working. They provided standard templates, standard agreements, and I found over the years, if we're able to go back to things that the professional bodies have created, have endorsed at the centre with the DH, then that does take down a lot of the barriers within companies, because even though it's not a standard corporate or agreement for that individual organisation, it's one that's acceptable because it's been through those high levels of governance. And so sometimes it's just looking to see what's out there that's already been created, and does that shorten some of the timeframes and have a level of acceptability.
Really helpful, thank you. Paul, I wonder whether you want to come in there, because I think you said some sort of quite stark things also about NHS culture, because I think it's very obvious that a small community group and a pharma company have very different cultures, but you throw the NHS in the mix and it's got its own culture and a half, hasn't it? And I just wonder whether you have any thoughts on how you dealt with that in your own work, or what comes to your mind listening to this conversation.
Yeah, I mean, it's complex, and the key thing, I think, is to identify those organisations who are exemplars in terms of, delivering high quality of care in a particular area, and understanding why that is, and then looking to see where the blocks may be in other organisations. And that, of course, involves a lot of detailed work. You've got to get close to people, and you've got to know people very well. You've also got to find where the energy is, and recognise that, a lot of healthcare professionals, people are only human. People will articulate that they will want to get involved and they want to contribute, but there's a big gap between articulating the reality of getting involved, and we've found that there is there's not as much leadership breadth as one would want to see amongst healthcare professionals. I'm sure that many of you will recognise that. And how do we enable as many people as possible who work in as healthcare professionals to develop leadership skills and to move into a space where they're comfortable in terms of exercising those leadership skills? That's very challenging in this particular period of time, because what's happened is that individuals have become very conservative with a small c in how they're looking at their roles and locking themselves
for survival.
Back in. And the last thing, I know I said some pretty tough things, but the signals are all there in the system. And as in my leadership role nationally through the Renal Association, going into the UK Kidney Association, I've got large numbers of my senior colleagues telling me they want to get out. And a lot of specialties have been cannibalized in this period to work right across the system in other areas. There's a lot of fatigue. I think it's about getting, we all individually and collectively need to measure how we need to be able to state where the key gaps are, how we need to be able to drive a national dialogue. People don't see the health system until they get right up close to it, of course. And there's a lot of assumptions in the general public that we may still have a functioning system, whereas the signals are that we've not got that. And that's writ large. Psychological health is completely, was disintegrating anyway, but COVID has led to a complete disintegration.
Yeah, I mean, we at National Voices have tried quite hard to sort of tell the stories of disrupted and delayed healthcare. We are much more challenged to get the numbers, but I'm always thinking there must be a space in which we can collaborate nationally, because I think the combination of the numbers and the stories is where it's at, really, to make the case. And I am really worried that, and you see it like in the parliamentary inquiry that started, Hancock gave evidence most recently, that we're still hearing the story that all the needs people had were met during the pandemic. And I think we mustn't let that land. I really feel very strongly about that we mustn't think it's all about elective waste, and we mustn't think it's all about cancer. There's so much unmet need now, and there was a lot of unmet need before the pandemic. But I think I would really appreciate if you spend some time thinking about it. We can have another conversation. Is there a way that we can, between professional bodies and patient organizations, bring numbers and stories together? Because I think we need to make the case that people sitting on a huge amount of unmet need, and the poorer they are and the more black they are, the more excluded they are, the more unmet need there is. Kirit, I wonder whether you want to kind of be the last person to comment in this section. You did say a couple of things in the chat, very appropriately challenging us on, do we have the data to show that we're reaching communities, and also highlighting the power of peer support, really. And I'm such a fan of peer support. I think it is our superpower as human beings to strengthen each other through sharing our stories. Kira, do you want to just comment on what you've heard?
Yeah, sure. Thank you. Firstly, I think it's some good comments came up by, I think, Mark around we have to be engaged as small organizations. We are kind of farmed out in terms of wanting to keep getting asked for goodwill support and using our kind of networks and stories, but in terms of lack of clear partnership. So I think unless those clear partnerships are there with us as patient organizations, specifically bespoke patient organizations, and we work on South Asian patients who have got diabetes and renal issues, they're the two areas that we focus on, and mental health. Secondly, there has always been a gap in terms of, I think the spotlight over the last 12 months, 18 months, because of George Floyd, has brought race back on the agenda, right? And all of organizations who have, sorry for being so blunt, but who have failed to address inequalities. Even COVID has given us the further evidence of inequalities that existed. So I think we've got to, organizations, institutions need to start having a different approach in terms of looking at the leadership, looking at how they engage and collaboratively work. I think we use the word collaborative, but I think it means different things to different people. So I think that's the first thing. And then I think we've always had a historical challenge, because obviously within the South Asian community, we know diabetes is prevalent, we know renal issues is quite prevalent, but in terms of developing culturally sensitive resources, and I don't mean let's translate leaflets, it's not about translations, it's about getting those patient stories and on a video who can share, and then hopefully that would encourage to address the confidence issue. But it's not just about confidence. There's a serious challenge around mental health now with some of our patients that we support, because not just a pandemic, but in terms of these issues that face, because they're waiting on a waiting list. Some of, could be waiting long for a kidney transplant. So hence, I think as partners who are here today, I think we've got to start working bespoke, but we have to look at targeted engagement, not trying to fix this kind of one size fits all. And I'm going to leave it there because I think time is of the essence. But I think the plea is about, let's change the way we work. And I think hence working with you, Charlotte, at National Voices, it's about, having that honest dialogue to say, yes, we haven't got it right. Yes, we need to look at what we do internally, but there's a will there. And I think that's why we have to continue that thread to do that. So thank you.
Super, thank you, Kieran. I think that's really important that we hear this challenge, these unequal outcomes we are all committed to doing something about. They don't happen by accident, they happen by design ultimately, and we need to change the way we design services and our partnerships and how we work. So we are really pleased that we work with Kieran and some of his colleagues and other organisations to really try to understand how services need to be adapted. Most recently, we've started a project on long COVID, and we're working with 6 organisations who work with often seldom heard groups on what their needs are around long COVID. You will all be aware that specialist services often underrepresent marginalised communities, Black people, people on low incomes, people with low literacy have a smaller chance to get through to a specialist service than white middle class people. And this inequality is even more so, it seems, around long COVID. So we are working with a number of groups to try to understand what needs to be done to put that right. So that's one of the ways we're collaborating with Kieran and his organisation and other organisations, for which we're really grateful. So we're only a small organisation ourselves, but we would never pretend that we ourselves have the reach we need to really bring all the intelligence and all the insight to decision makers, which is how we see our role. Right, I see 2 people have raised their hand, but I also, Ella wants me to briefly flag up 2 Mentimeters and what you all collectively said. Ella, do you want to show those now?
Yes, I will just share my screen. I go here. One second.
I did see it there briefly, but now it's disappeared.
Oh, you know what? Okay, 1 second. Easy to show it this way. Here we go.
Right, not that many of you did vote in our Mentimeter, never mind. So half of us have formed partnerships like that, and maybe another half are trying to do so. So I hope there was something in our discussions today to guide your thinking and maybe put a bit of grit in the oyster. And then there's also someone who says no, which is interesting. Ella, what's the next?
We did a word cloud for the most important factor for a good partnership. And this had a few
so trust comes up, and I think that obviously speaks to kind of relationship and culture, and we have tried to cover that. Transparency was discussed, and that's obviously something that we discussed in line with the sort of governance arrangements for pharmaceutical organizations. Common purpose, I mean, that all kind of speaks to similar questions. We can share all of the slides and these results as well with you. I can't see now, Ella, maybe you can help me, who, if you take that down so I can see more faces, who asked to speak. I saw Anne flash up on the screen, and we maybe have time for one or two more quick contributions. And do you want to, did something trigger something in your mind as you were listening?
Thanks, Charlotte. I think the other was Peter as well. Apologies. I think he had his hand up first, but if you don't mind, Peter, it was just a quick comment. It was really when you were talking around peer review, peer support. I think that sometimes there's been some great projects done. I know around Birmingham, working actually with Kidney Research UK, there was a great piece of work done, particularly with the South Asian community in the east of Birmingham. Actually, it's a really interesting debate. Once you've got that initial piece of evidence, how do you then take it and expand it to make it a substantive service within the NHS? And so I think on another occasion, it'd be great to have the debate about when we've had these partnerships, these programs, how do you then embed them for the long term?
Yeah, absolutely. And maybe Kiri's even aware of that work, because it's not far from where he is based, I think. Right, and then I think, was it Paul who wanted to come in?
It was me, Charlotte, if that's okay.
Absolutely, do.
Yeah, it was just on Kirit's point about the, I guess, tailoring the approach to different groups rather than just, saying, can you whack that through your translator and roll it out, which isn't really what we're trying to do. I guess I worked for, before my kind of previous, in a previous life, I worked for 4 years building patient support and adherence programs for different pharma companies. And I have on occasion been asked can you just translate? Which is why I guess I'm proud to be able to say that there's a project we haven't touched on today where we have been doing an awareness plan for an awareness campaign for a South Asian population who certain parts of India, Bangladesh and Pakistan have a higher prevalence of hepatitis C there, not due to the injecting drug use, but due to kind of things like medical hygiene and some other things as well. So the approach that we took to try to reach that group is one based around trying to activate perhaps not the first generation people who are now maybe in their 50s and 60s, but trying to activate members of their family. And we've seen comedy as a really good vehicle to do that. So that campaign has gone live as of the last couple of weeks. But for obvious reasons, we've delayed that over time, but really proud to kind of say that's gone live now and accurate. And anyone else who would like to go to it, more than happy for you to take a look and see if it's see if we've hit the mark, and if you can share that wider, and are happy to do so, then please do. So I'm happy to put the link to that into the chat as well.
Right, that's really interesting to hear, and I do think Kiri might well want to pick that up, and other people as well on this call. I'm going to assume that the people who are on the panel and who spoke are happy to have their email addresses shared with everyone, so that people can make contact and continue the conversation online. I don't think we can make this assumption about everybody who attended, but please do reach out and we can also make a connection if you would like that. But we might send out the email addresses of the speakers if that's okay with you, so that if there is stuff that you want to learn from each other or take forward, we can enable that, because that's what makes us happy, is if our work helps people build good partnerships. So all that remains for me to say really is thank you everyone. I appreciate Monday morning is a busy time. You all have probably slightly anxiously with one eye been looking at your inbox thinking, oh, when do I get to this? You will, it will still be there. But this has been a really interesting conversation, and thank you so much to our colleagues from Gilead and from Baxter and from Fresenius Medical Care and from Kidney Care UK and from Change, Grow, Live. I have learned a lot. I did not know half the things you spoke about, and that's always a nice feeling. And there's much to think about in terms of how can we make this better. And we will continue this conversation and this thread in a sort of loose way, come back to it, return to it, because this is sort of our bread and butter, to make connections between people whose agendas are only partially overlapping, but who want, at least on one thing, the same thing. Right, we have another big event coming up on Monday. On Wednesday, we've already put that in the chat. We're talking about the emotional and mental health needs of people with physical ill health. And we're setting up a campaign then, so do join us. It's going to be a very interactive event where we're all going to ask you to do stuff. And we are then later on also next week, I think, or the week after, launching a smallish report on how NHS admin impacts experiences and equality around healthcare. Which is, when you start talking about it, everybody's got an anecdote, but as far as we know, it's never been looked at systematically by anyone. So we continue to be busy. We are here for partnership conversations and the rest, if that seems attractive to you, and do stay engaged and have a good week. Thank you. Bye-bye.